paclitaxel coated balloon angioplasty versus drug-eluting stenting in acute MI. Basically, the concept is it possible that we can leave nothing behind in the treatment of acute MI? As we all know, the treatment of choice in STMI is usually stenting, but there are some limitations of drug-eluting stents. It causes vascular inflammation and hypersensitivity to the polymer coating, which may lead to acute stent thrombosis or thrombosis at the later end. There is unequal drug distribution. It does hamper the future CABG options, and most commonly there is late luminal enlargement and restoration of the vasomotor function of the arteries, both compromised due to the permanent metallic cage, and there is long-term requirement of DA. So to overcome some of these limitations, one had come with the concept of drug-coated balloon.
So how does it hamper the future CABG?
Basically, if supposing there is we are going to join the graft to the arteries. If at all in a young patient we have done stenting and that person undergoes stenosis, now due to the excessive inflammation and all angiointerplasia, the graft placement becomes difficult. Supposing there is a long stent placed in an LAD and you want to join the grafts to the LAD, mostly it would be joined at the distal end of the portion. So the
સ્ટેન્ટ વાળો એરિયા ગ્રાફમાં લેવાની જરૂર ક્યારે પડતી હોય છે? તમે આટલા વર્ષમાં જોયો ક્યારે કે અહીંયા સ્ટેન્ટ મૂકીને ત્યાંથી મારે ગ્રાફ બી મૂકવો પડ્યો?
એવું નથી જોતું, but it's like one of the latest
theoretical possibility.
rare complication that is not
ટ્રાયલમાં જે બી લખે છે બધું તમે ના બોલો અથવા બોલતા પહેલા રેરિટી અનકોમન આવા શબ્દો વાપરો.
એટલે સ્ટેન્ટના ડિસ્ટલ જે એન્ડ હોય ત્યાં યુઝ્યુઅલી બાયપાસ મૂકે ને પછી એ બાદ આવવાનું કરતે ત્યાં સેમ્પલ
very rare because if CABG either our young was the first option we give them and old age normal, so anyway that would be very small stent in the
In any case that stent instant thrombosis is never going to hamper bypasses.
It's a very rare, but that is
you unless until left main માં મૂક્યો તો અને ઉપર સ્ટેપ માં બી હતો અને ભવિષ્યમાં ત્યાં જરૂર પડી બરોબર તો it's a different story ને.
It is very rare of
આમાં તો it's my way or highway.
એટલે લિસ્ટ ની અંદર આવે ખરું.
Kiran bhai, when you want to promote the other thing, you have to find out the minuscule problem of others.
એટલે લિસ્ટ ની અંદર આવે.
Obviously.
લોએસ્ટ પોસિબિલિટી વાળી લિસ્ટ માં આવી જાય.
Right.
basically conventional semi-compliant angioplastic balloon which is coated with anti-proliferative drug, mostly paclitaxel, and it is released into the vessel during inflammation of the balloon. The infiltration usually occurs at nominal pressures with specific minimal inflation time, which is usually 30 to 60 seconds. The active substance on DEB is lipophilic with high absorption rate through vessel wall to compensate for the short period of contact. So this is the components of DEB. It has the drug which is paclitaxel and the agent. Agent is usually a urethane or iochromide substance which is also lipophilic, which helps in getting reabsorbed in the vessel wall. So, usually why paclitaxel? Because it is highly lipophilic, rapid intracellular uptake and retention of the vessel wall is nearly for a week, and it acts by irreversible binding to microtubules, inhibiting cell division and migration. So the structural intracellular changes causing long-lasting effects. Short incubation time 3 minutes, and with paclitaxel almost completely inhibits vascular smooth muscle proliferation for at least 12 to 14 days. The third generation includes the zotarepimus drug, which is also lipophilic, but still the trials are going.
So this drug, it is being released from the tip of your balloon or all throughout the length?
The entire balloon is coated with the drug.
What is the size of that balloon?
Depending upon the lesion required, the balloon size is taken. It's normal the way we dilate 2.5 mm to 32 mm balloon. So whatever according to the lesion the balloon is required, it is available in that size.
So we apply balloon and the drug is released just within the lesion only, not all throughout the vessel, right?
Yes. It is not like supposing this is the lesion.
Okay. So તમે જે પાર્ટ હાઇલાઇટ કરો છો ત્યાં જ મૂકો છો.
ત્યાં જ મૂકવાનું અને ત્યાં જ concentration is decided like 3 micrograms per mm of that drug coated. So every mm has 3 micrograms of the paclitaxel coated around it. And it is usually 3 times higher than the normal drug-eluting stents. The reason being that 10% is lost while we are actually guiding it through the catheter. So, next 70 to 80% of the dose is washed away by the blood flow. Only 10 to 20% of paclitaxel is transferred from balloon surface to the vessel. So that is the reason that every mm has
0.3 to 0.6 microgram per meter square is transferred.
Yes, and that is the amount of drug which is coated in drug-eluting stent. So the reason of keeping it 3 times is for this reason, because there is going to be a loss. At least 70% is going to be lost.
I will assume that.
Huh, sir? So this is the thing. PCB delivers a dose to target in a very short time, that is higher than the total dose released by drug-eluting stent over many weeks. So with this immediate drug release, there is no need for polymer for drug administration. Polymer is basically thus avoiding the chronic inflammation and the late thrombosis that occur in drug-eluting stents.
Over many weeks per specify નથી કરી.
Sir,
કેટલા
DS માં હોય છે 1 microgram maximum per mm. So a stent, drug-eluting stent નો release of drug occurs over weeks. A stent માં આપણે 0.1 microgram per mm જેટલું જ drug ગયું છે. એટલે એટલું જ ultimately the drug delivered, the entire amount is delivered in few minutes in comparison to the that amount delivered over weeks.
પણ એની ઇફેક્ટ તો બેટા ડ્રગ એલ્યુટિંગ સ્ટેન્ટ કરતા વધારે કઈ રીતે ચાલી શકે? ઇટ્સ લાઈક કે એક તમે ડીમો પ્રિપરેશન આપી દીધું ને એક તમારું ઓવર અ પીરિયડ ઓફ ટાઈમ ધીમે ધીમે આપે છે.
એટલે આને લોડિંગ ડોઝ કહેવાય. લોડિંગ ડોઝ કહેવાય.
Loading dose કહેવાય. એટલે basically they wanted to show in this કે જે આપણે drug eluting stent મૂકીને પાછા આવતા રહે છે, so that requires long term DAPT environment. So is it possible that we can treat the MI, there is no further thrombosis and we don't need to leave behind anything in your body?
સો એ ડેટા આવશે ને આગળ.
હા,
ચલો
એટલે
સાંભળીએ.
એના ઉપર જ છે.
ચલો
It
સાંભળીએ.
is a more debatable thing.
હવે
70-80% is release out.
But this is something new. એવું છે.
અને લાસ્ટ સેન્ટેન્સ કે with this immediate drug release no need for polymer.
Exactly. So because in DES the most common cause of late stent thrombosis or acute stent rejection is the polymer component along with the drug, which has to be used so that it is released slowly. So if we are removing the polymer, there is no chances of any vascular inflammation and late thrombosis. That is what they want. So 3 generations of DEBs are available. Mostly first and second have paclitaxel. The third is the sirolimus or zotarolimus one. It is also found to be lipophilic. What the difference is between these is that they are the first generation is aerochromate. These are urethane, so it has less chances of inflammation or reaction or allergy thing, and there is controlled release of the drug at the site of lesion. So between the generations, that is the difference. And the coating, there is improved coating, advanced polymer free or hybrid nanoductic in the third generation. But usually first generation EVs were used in this.
So is this improved control is automatic or manual control you can also do?
No sir, basically based on the binding of this, see, this has iochromite and all these has urethanes and all that. So the concept is when you are inflating, the contact with the vessel surface and the polymer institutes a reaction through which the drugs are released because they are first bound to the agent. So the concept of improving.
So basically there is no manual control.
No manual control, sir. Manual control is only for inflating the balloon and placing the lesion. The rest everything happens based on the reaction occurring with the vessel wall surface. And safety profile again, third generation minimal inflammation and indications usually instant rhinostenosis and complex and bifurcation lesions. Moving forward, there are some practical points that has to be noted. Proper vessel preparation has to be done. But pre-dilatation balloon should be at least 1 mm smaller than the intended drug-eluting balloon. Adequate 1:1 sizing between the vessel and DEB, which can be confirmed with IBIS. Short transfer time from access sheet to DEB information. So one has to practice that no longer time should be happen to loading the balloon. Single prolonged inflammation of complete drug release still manufactures recommended time, which is usually maximum 60 seconds. And if not tolerated, fractional release in quick intermittent inflammation still recommended time is complete. So these are the things to be noted while using DEB. So coming to the indications of DEB, only one recommendation is available.
So how you decide whether it is not tolerated and we need to deflate the balloon, and again you can, how you decide that? If not tolerated, then fractional release. So how you decide? Oh, આ તો tolerate નથી થતું, ચાલો deflate કરો પછી પાછું કરશું.
मतलब सर आपको बलून भूलसे नहीं, તમારું रीजन એટલે ટોર્ચર્સ કેવી રીતે હશે તો supposing I need mostly 10 mm.
So that's a technical point.
Technical point, yes. So if it's I'm ballooning at 6 mm, usually I can see the balloon is being opened up and the drug, well, you can see that it has attached to the well surface. And if not, then quickly deflating and inflate. The only indication for DEB as of now is in instant stenosis, and it has received 1A recommendation in EAC guidelines 2014 of myocardial revascularization. It is same in 2018, but I was not able to get the entire guidelines. So drug-coated balloons are recommended for treatment of instant stenosis within bare metal stent or drug-eluting stent. Other indications which are in search is for DCB in small vessel. Still we use it. Over here they have considered small vessel disease as less than 3 mm of vessel diameter, and because late lumen loss occupies a greater percentage of respective vessel diameter, resulting in higher rates of ISR and adverse events. So two trials have gone undergone. One is basket small 2 trial, which showed paclitaxel iobromide coated stents were non-inferior to second generation DAs. They have not shown they are better, but at least there were no difference in the changes. Another trial was Store SVD China trial, which again showed non-inferior to the DAs in terms of percentage diabetes stenosis at 9 months and comparable target lesion failure rates at 1 year. But in all of these, adequate lesion preparation is mandatory. Another prospective indication is for de novo large vessel lesions. The trials that are undergoing is debut trial, so that is DCB against bare metal with individuals with high bleeding risk. So at 9 months there was no acute vessel closure and there was 1% of MIS. In Pactide Enstemmite trial, again DCB versus BMS or DS, and there was non-inferiority of DCB compared to metallic stents. However, 15% required beta stent. Alliance registry is ongoing to decide for large vessel lesions still. So presently the indications without recommendations include patients with high bleeding risk or lesions for which clinical efficacy of DS is not well established. Usually an osteal LCS lesion or a jailed side branch, which is small.
What is jailed side branch?
When you are doing bifurcation, we keep one wire in the side, supposing LED in diagonal. The lesion is at the bifurcation of the diagonal. So main wire is going to go in LED, one wire is going to go in diagonal. So in those we can do DCB and COM. Same thing, DCB in bifurcation lesion. Approach for bifurcation lesion is appealing, but so that it avoids the carina shift, but it is challenging because it can lead to dissection of the carina. But still they have undergone DCB with directional coronary arthrectomy. That's basically a concept of rotational arthrectomy. So it's an option to avoid metal at least at the bifurcation. At 12 months, the target lesion failure was 10.9% and binary restenosis was 2.3%. Binary restenosis is restenosis more than 50% of the extent.
So what are the antiplatelets you give after paclitaxel coated?
Same.
Dual antiplatelets
Dual
only.
antiplatelets. Just the duration has reduced. For 3 to 6 months. That is 6 to 12 months.
So major positives
They have just under, this is just the start.
exploration challenge.
Challenge. Only one thing has got recommendation is instant restenosis, and that also usually when the person has undergone multiple stenting, like twice or 3 times he has gone restenosis, there is no space to put another metallic stent. So then DCB is a better option.
So that is one thing કે restenosis થયા રાખે છે, પણ ઘણી બધી વાર આપણે મલ્ટિપલ સ્ટેન્ટ્સ નાખતા હોય છે, તો ત્યારે છે જરૂરિયાત, ત્યારે આના પર ડેટા.
This is a better option because already if I have 2 metals, I am going to place third metal. There is no chance the lumen is going to reduce in size. You are not going to get the
Exactly.
reference.
So currently Exactly, is it there in guidelines કે તમે multiple stent નાખો તો આ use કરો?
હા એટલે instant renostasis ની
Instant નહીં.
ના multiple
Did.
એવું mention નથી કર્યું.
Oh.
They have just mentioned ISR. They have not mentioned કે કેટલા stents પછી you should prefer કે a person has gone twice.
કે આજકાલ multi stent is in very much fashion. 3 stent, 5 stent, 6 stent નાખતા જોઈએ છે.
એ નથી એવી રીતે
એટલું નથી, right?
ના ખાલી instant નું એવી રીતે recommendation આપ્યું છે. In very long diffuse long lesions again has preferred more we should be doing because there are high chances of overlapping the stents which causes more chances of stenosis at the site of overlapping, and the vessel geometry will be also altered because of the curves and structure of the stents. So there is this hybrid approach which combines DES at the proximal end and DCB at the distal end, which is narrower. So DCB only versus hybrid approach. There are comparable rates of MACE 20% to versus 22%, and target lesion revascularization is also equal 9.6 to 0.84. There is this hyper-pilot study which is going on, which will evaluate 12-month clinical outcome of hybrid approaching 100 patients with diffuse CVT.
So suppose currently you have a patient of long lesion and you are supposed to put a DES. You will put single stent or how will you approach?
So that becomes more of a clinical. If supposing LED is the longest vessel we go, and if the caliber of the LED after mid segment is very small, usually we see there are tapering LEDs. So if at all there is a block, I would prefer going for a DCB in the distal end. Till mid segment I will put a DES. So at least the maximum part above the blood flow is going on. The purpose of going for DCB because I won't have a stent for that small caliber vessel.
So if you don't have DCB, then you will put a single stent or you will put double stent or how will you cover
till mid
this?
segment I will do stenting नीचे balloon भरने पाचा.
Okay.
Simple angioplastic balloon की थोड़ी inflammation inflation करी पाचा खोली. But then there are high chances કે એ ફરી બંધ જ થશે. That is why the hybrid approach. કે જો ત્યાં બી હોય તો it avoids the
DES મૂકવો હોય તો longest possible કેટલો રાખવો જોઈએ? 48 થી વધારે ના કરાય.
48 જેટલા
આવતા બી નથી.
હા એ લાર્જેસ્ટ સાઇઝ
Maximum
પછી આપણે
38
ઓવરલેપ કરવું પડે એટલે 60 mm નું if entire માં diffuse LED only single vessel entire LED is diffuse. I don't want him to go for CABG. At least મારે mid segment સુધી તો કવર કરવું જ પડે.
So that is why DCB is here, right? That is what we are discussing.
Exactly. So for the tapering distal I know there are plaques. I want to remove them. If I just do balloon and come, there are high chances it will again cause blockage. So if there is a drug which is there for 14 days, at least the chances of closure is less. So that is one use, but yet no recommendations for this. The trial is going on. Coming to our trial, DCB in acute MI, the regulation trial, the objective was to evaluate the safety and efficacy of paclitaxel coated DCBs compared to DS. DS in STEMI patients undergoing primary PCI. Primary focus was on fractional flow reserve as a measure of functional success. The duration was October 2014 to November 2017. Multi-center prospective randomized control trial, only single center in Amsterdam. STEMI patients were randomly assigned to either DCB or DES group. The inclusion criteria is the patients presenting with STEMI, single de novo lesions in coronary artery. So after the patient has been taken, thrombosuction has been done. If balloon is required, balloon has been done. If residual stenosis was less than 50% by visual assessment, after thrombus aspiration in case of visible thrombus and mandatory pre-dilatation, those patients were included in the study. The exclusion criteria or the bifurcation requiring complex stenting was excluded. Patients who were having contraindications to DAPT were excluded. History of MI, stent implantation less than 1 month, cardiogenic shock or intubation were before randomization were excluded. The intervention procedure, pre-dilatation has to be done in both. Performed in all patients using standard angioplastic balloons. Residual stenosis was assessed. If residual stenosis less than 50% taken for trial, if more than 50% excluded and stenting was done. That's what these were the stents that were used. Usually all the DCBs were of paclitaxel coated, and the Pacibate, ticagrelor, and ecosprin, depending upon the patient they were given. Bailout stenting with bare metal stent was advised only in case of residual stenosis of the treated lesion more than 50% after balloon dilatation and with successfully large balloons, or there is a coronary dissection greater than or equal to type C leading to vessel closure. Successful PCI was defined as for DCB, diameter stenosis less than 30% by visual examination and any flow grade more than 2. For DES, it was diameter stenosis less than 20%, TB loading more than 2 was examined.
This bailout stenting was in both the group.
DS તો સ્ટેન્ટિંગ જ છે.
બરાબર છે, પણ એમાં બી આ રીતે બેલઆઉટ સ્ટેન્ટિંગ બીજું આજુબાજુ તે કરતા હતા.
ના, આમાં લોકો એ એટલે ઇન્ક્લુઝનમાં કેવું સિંગલ વેસેલ જ કરવાનું હતું. એટલે સપોઝ ડીસીબી માં એક ફેલ ગયો તો પછી બેલઆઉટ સ્ટેન્ટિંગ થયું.
So this is for DCB only.
For DCB because DS we are doing proper stenting.
Okay, હા, સિંગલ જ હતો એટલે બીજાનો તો કોઈ સવાલ નથી.
સવાલ જ નથી. Endpoints. The primary endpoint was fractional flow reserve, measured 9 months post procedure to evaluate coronary blood flow. FFR threshold for adequacy was more than 0.90. Secondary endpoints. The main was late lumen loss, that was the difference between minimal lumen diameter immediately after the procedure and at 9 months follow-up. MACE included death, recurrent MI, target lesion revascularization. Stent thrombosis only in DS group and non-CABG related major bleeding. So this was the study design. 120 patients were enrolled, 60 in both the groups. 59 were treated with DCB and 61 were treated with DS. That one required bailout stenting. Dropout was loss of refusal to follow up by 2 patients and refusal invasive, like they were not ready for FFR. So those were like 18. So DCB 9-month follow-up were 41 people, and for drug-eluting stents were same, nearly same, 43 people. Among these, FFR was not done, only IFR was performed in 5, but basically 7 did not undergo proper follow-up. So DCB FFR measurement was done in 34 and DES FFR measurement was done in 39.
IFR શું છે ભાઈ?
So that is similar to fractional flow reserve only. That is basically it considers the difference between the aorta and the artery.
Full form.
It is wave-free ratio. I forgot the I. The concept fractional flow reserve આપણે catheter stent થી કરી આમાં out the end point is the aorta. That is
So you put a catheter in aorta?
Yes.
From where?
It's
Same approach?
Same approach, but એમાં ઓલું wave-free ratio છે and the measure. I forgot the full form, so I'll tell you. But basically wave-free ratio during diastole જે wave-free થાય એમાં aortaમાં ત્યારે શું pressure હોય છે અને તમારા coronary arteriesમાં શું pressure હોય છે એનું
But
difference.
it should be rather more challenging. aorta થી તમારી ટાર્ગેટ વેસલનો ડિફરન્સ તમારે કરવો તો એના માટેની પ્રોસેસ ઈઝી કે FFR ઈઝી if you are doing intervention?
They were એટલે આમાં it was 5 mention કર્યું છે. It is more and you have to mention during the diastole period.
તો બેન આવું બધું ડિટેલ વાંચી ના આપજો યાર કે આ ખબર ના પડી.
ના it's wave-free ratio, but I believe this. Exactly.
ચલો આવતા વખતે કહેજો.
Baseline characteristics, usually they have kept same. Age, mean years were 57 years. Diabetes, comorbidities were kept same. Loading dose, the same according to passive ticagrelor or radial approach was, all those things were kept same. The one vessel was 44. These were the vessels that were diseased vessels. TVD were between 4 patients. The infarct-related artery, most commonly it was RCA which was being used, and TB grade flow was achieved in pre-procedure. 50% had zero, acute, 100% occlusion was there in both the cases. the difference is not significant. So DCB is not inferior to.
It was at the end of 9 months.
At the end of 9 months. There are, so the 9 months, 2 years and 5 years. The physiologic primary endpoint was at the end of 9 months, FFR. So this showed that it was not statistically different. The secondary endpoint for this was late luminal loss. Again, p-value was 0.51. Late luminal loss average was 0.05 mm in DCB, and it was a bit higher. DES was 0.12 mm, but still not statistically different. This is the table for the result. The fractional late luminous was more in DES, and then major part we have to see is in the clinical endpoints, because the follow-up studies were for clinical endpoints. In that maze, there was no cardiac death that was being seen. There was one death at the after 5 years, but that was non-cardiac. Recurrent MI was 0. TLR was 2 patients in DCB and 1 patient in DES. The LGF was maintained and DAPT was given in everything. So we will move forward with the clinical endpoints for the rest follow-up.
L કેટલા months પર હતું? સેકન્ડરી એન્ડપોઈન્ટ જે લ્યુમિનલ લોસ હતો
એ 9 months વાળું છે.
એટલે 9 months વાળું
9 months માં જ FFR થયું હતું, પછી નથી થયું.
પછી નથી થયું.
પછી નથી. Then follow-up is only for clinical endpoints. Discussion. So basically to point out the efficacy of DCB versus VABs based on FFR was not non-inferior. That was shown. Reduced late luminal loss with DCB was only 0.05 mm compared to 0.12 mm. Comparable clinical outcomes. The TLR and major cardiac events were not so much high in DCB. They were comparable. So that is what they wanted to say in this 9 months. The limitations were very small sample size. Single lesion was included, excluding more complex or bifurcation lesions or calcified lesions. This limits the applicability for finding broader stomach population. Short follow-up period for 9 months and selection bias because all the residual stenosis was less than 50%. So this trial had 2-year, again in Jan 2020, an article came for 2-year clinical outcomes of this trial, and the key findings were 109 patients were follow-up. In DCB group, 3 patients had experienced MACE. Only 1 event had occurred of TLR from 9 months to 2 years. But even
What sort of mess it was in LGB?
sir,
એ જે 3 પેશન્ટ માં મેસ હતું એ કયું હતું?
હા એમાં સર બેમાં એકમાં તો acute vessel closure હતું TLR અને બીજામાં બેલ આઉટ સ્ટેન્ટિંગ કરવું પડ્યું. આ ત્રીજામાં ફરી this was the third case that happened after 9 months to 2 months. Again he had MI, so target lesion failure નીકળ્યું હતું. So that was included in this. So that was the 3 ways that had occurred.
જેના માટે કરવા જતા હતા એ જ થયું.
Age 3 ways. એટલે DS 1 હતું. So 2 years more only 1 event had occurred. So they wanted to show it's still it is safer. Same thing, other May 2024 5-year clinical outcomes were released, and in that it had shown there was 1 event of MI which had occurred in DES group.
So this is from 2 to 5 only, no?
2 to 5. So after 2 to 5 years there was no event that had occurred in the DCB group.
5 વર્ષ પછી બી 107 જણા ફોલો અપ માં છે. It's a big number.
Yes, 107 were
સારું કહેવાય.
વધારે જ આઈડિયાલિસ્ટિક છે.
So this is to summarize that 9 months there was TLR. In long term there was no major cardiac event that was seen in DCB group. So basically it may be efficacious in selected patients presenting with STEMI, but there is more evidence needed with larger and adequate randomized
Okay.
trials.
Is these encouraging results?
That is what they have. So 107 patients માં 5 years સુધી હજી MI નથી થયું.
તો બેટા તમારા કાઉન્ટર પાર્ટ ને જે જોવો ને
એ નહીં આવે.
અને problem is the lesions had less than 50% residual. effect of it sometimes if there is a young patient have a thrombosuction, the vessel part is good, there was only one thrombus, I keep him on DABT and stuff. There are less chances of him coming with recurrent MI.
It's not only stent related issue which causes recurrent MI. બાકીનું
As
બધા
due to other factors, they have not included or
અને બીજો ક્લચ પોઈન્ટ એ છે કે તમે દર વખતે FFR કરીને બતાવ્યું હોત તો હજી આપણને ત્યાંની લોકલ પેલી વસ્તુ ખબર. હવે તમે ક્લિનિકલ પર આવી ગયા છો
હા,
તો
તે-
ક્લિનિકલી તો દુનિયા ક્યાંની ક્યાં આવે છે ક્યાં કંઈ
it છે કે and there are only 100 patients જે તમારા એ આવે. So how you have taken
સિંગલ સેન્ટર સ્ટડી.
તો તમારે
single center has to.
કોઈ પણ વસ્તુને ઇન્ટરવેન્શન વાળી ગાઈડલાઈનમાં ઇન્કોર્પોરેટ કરવા માટે મિનિમમ કેટલા પેશન્ટનો ડેટા હોવો જોઈએ? Have you ever thought? Or can you share?
100 at least.
એટલે ખબર છે કે એમને
નથી.
ગેસ કરો એમ?
નથી.
આ બી મને IFR બી કહેજો ને આ બી કહેજો કે કેટલા આંકડાવાળો ડેટા આવે અને પી વેલ્યુ સાથે તો ડાયરેક્ટ ગાઈડલાઈનમાં સજેશનમાં કે રેકમેન્ડેશનમાં એટલીસ્ટ ચલો ગાઈડલાઈન ડાયરેક્ટ ના આવે પણ કન્સેન્સસમાં કે એમાં ક્યાંક આવી જાય. આવું જોજો કહેજો પછી.